Recording now. Dr. Terry Redmond is the director of the Institute for Biosecurity and professor in the Department of Epidemiology and Biostatistics in the St. Louis University College of Public Health and Social Justice. She's a PhD nurse researcher with an emphasis in infectious disease emergency preparedness. In addition, she is board certified in infection prevention and epidemiology and an APIC fellow. Her past work experience includes research and clinical practice with HIV/AIDS patients and hospital infection prevention and epidemiology. In her current position with the Institute for Biosecurity as the director, she is responsible for managing all aspects of the Institute's certificate, MPH, and PhD academic programs, as well as teaching classes in the programs and conducting research. Her research areas of focus include healthcare and public health professional, disaster preparedness, long-term use of respiratory protection, and addressing barriers to vaccine uptake. She publishes and lectures on bioterrorism, pandemic planning, emerging infectious diseases, and infection prevention practices on a national basis. Dr. Redmond has served on several national and international task forces and committees aimed at minimizing morbidity and mortality related to emerging infectious diseases and bioterrorism threats. Examples include being a member of the Association of Professionals in Infection Control and Epidemiology, Ebola Task Force, and being a former member and chair of the APIC Emergency Preparedness Committee. So with that being said, you can be rest assured that Dr. Terry Redmond knows what she's talking about in this and has done her research. And we look forward to hearing everything that she has to share and everything we can learn from her. Terry, can you get your slideshow going?
It's up. Can you not see it? Let me hit share screen again. I'm telling it to do it. It's asking me if I want to leave the meeting. I'm hitting screen share or share screen.
Yeah.
Is it working now? There it goes.
Yep.
Oh, awesome.
Yep. You got it. You got it.
Awesome. Thank you.
You bet.
Okay, so I will get started. So the objectives for my presentation today, I'm going to talk about why long-term respirator usage planning is needed for hospitals and healthcare systems. I'm going to cover crisis standards of care related to respirator supplies during disasters. And lastly, identify physical, psychological, and behavioral findings that can place healthcare personnel at risk when they're wearing respiratory protective equipment, especially for long periods of time. So I want to start with a couple of disclaimers. This webinar was actually created, it was originally intended to be presented in August of this year, and it was intended for future disaster planning for infectious disease disasters. So this was before COVID-19 actually hit the planet, actually. So this presentation is not specific to COVID-19, but I am going to be addressing issues related to COVID-19 that are specific to planning for long-term use of respirators during this event. But my other disclaimer here is that, as you all know, information on COVID-19 is changing every single day. And so the information in my slides is current as of last night. I checked to make sure that everything that I had in my slides was still current. But you should always check the CDC website during an event, including during COVID-19, because the recommendations do change on a fairly quick basis. And so I always want to make sure that whatever hospital or healthcare facility you work for, make sure that you're using the most current recommendations, because some of what might be in planning guidelines might not be necessarily what the CDC decides to implement during an event. And I'm actually going to talk about that later on when I'm talking about their pandemic planning guidelines versus some of the differences in terms of what they're recommending for COVID-19. Okay, so let's start first with what kinds of disasters we're talking about in terms of planning for the need for long-term use of respirators. Respirators or respiratory protection are most likely to be needed for disasters that involve an infectious disease, meaning that the infectious disease is the cause of that particular disaster. And that includes three different categories of disasters. It includes bioterrorism events, where it's a man-made intentional use of a biological agent to inflict harm or death onto us. It can include outbreaks of emerging infectious diseases, where that disease is either an airborne spread disease or it's a respiratory droplet spread disease that we think might have the potential of being airborne, where we're not quite sure on the epidemiology, which is where COVID-19 comes in. And we'll talk about that in a minute. And then the third category would be pandemics. So for these kinds of disasters, they're unique from weather-related natural disasters, and there are unique planning and response challenges, including this need to have a stockpile of respirators or respiratory protective equipment, and also to use potentially long-term use of respirators among our healthcare personnel. So with infectious disease disasters, because they are unique from other kinds of disasters, the Joint Commission has standards that are specific to these kinds of events. So the Joint Commission standards that are specific to what I'm talking about today in terms of respirator usage and long-term respirator usage include the IC.01.06.01 standard, which covers both the need to have isolation surge capacity and also potentially the long-term use of PPE. What this standard relates to is the need for hospitals and healthcare systems to be able to manage a large influx of contagious patients, which is exactly what we're seeing right now with COVID-19, or in some areas are seeing with COVID-19, and it's likely to occur across the United States in the upcoming weeks and months as well, but could also occur during other kinds of events such as an influenza pandemic. So if you look historically at what has happened during infectious disease disasters, in particular influenza pandemics, because those are the events that we have the most data on, what the research indicates and what the epidemiology has shown us is that patient surge during these kinds of disasters are different than what we see with natural disasters that are weather related. What we tend to see are very large, long patient waves, or these long surges of patients to the healthcare system. And this is exactly what we saw during the 2009 H1N1 pandemic, where there were two pandemic waves during that outbreak. And of course, you know, the pandemic lasted much longer than just those 2 6 to 8 week waves. But we saw two distinct patient surges during that pandemic. And so the H1N1 pandemic in 2009 sort of happened almost exactly the way epidemiologists had predicted that it would happen. However, that's not necessarily always what we're going to see during a future infectious disease disaster. So for instance, for COVID-19, it's possible that we might have longer waves of patients. So if you look at what happened in China, for instance, they had a much longer patient surge than just 6 to 8 weeks in length. So I'm really not good at predicting what's going to happen during COVID-19. There are multiple scenarios that have been discussed about what we might see. But what I anticipate at a minimum is that we will see a patient surge in many communities, and it's possible and probable that it will be prolonged up to 6 to 8 weeks and possibly even longer. And so that's going to have unique challenges for hospitals and healthcare systems to be able to respond to those patients and be able to help protect our healthcare personnel as they're responding. So there are approximately 12 million healthcare personnel in the United States, the vast majority of which are female. And we know that for events that involve either a respiratory droplet spread or airborne spread disease, we have to have respiratory protection for our workers. Technically, respiratory protection is used for diseases that are either airborne spread, or if it's droplet spread, that we think that it might possibly also be able to be spread by airborne, and so we take a more cautious approach and we still use respiratory protection during those events. And I'm going to talk about the difference between respiratory protection versus masks in just a minute. It's also important to know that respiratory protection is an OSHA requirement to protect healthcare personnel from occupational exposure during these kinds of events. So if you look historically at the risk to healthcare personnel during past infectious disease disasters, what we have found is that healthcare workers are very often at high risk of occupational exposure and disease during these events. So for example, during the SARS-CoV-1 outbreak in 2003, healthcare workers made up almost 2/3 of all of the infected individuals. So most spread of SARS-CoV-1 actually happened in healthcare settings versus community spread, which is different than what we're seeing during SARS-CoV-2 or COVID-19 as it's also called. MERS-CoV has also proven to be, or the MERS coronavirus has also proved to be, to put healthcare workers at higher risk than the general public in terms of infection and exposure. And of course, during the Ebola crisis of 2014 to 2016, we saw healthcare workers had a 103-fold higher risk of exposure and illness to Ebola compared to the general public. Now with COVID-19, the early data that we have, and of course, at this point when we're actually doing this webinar, this is still the early times during the COVID-19 response. But if you look at the occupational data that we've gathered so far, starting with the data from Wuhan, China, what we see is that most of the cases of healthcare workers that became infected early on during that outbreak happened because we did not know that there was human-to-human spread. So the early cases we believe to be zoonotic in nature, and so we knew that there was animal, or we suspected animal to human spread, but we did not know that the disease was actually spread from person to person. So therefore, many healthcare personnel were not wearing the appropriate personal protective equipment, including the correct respiratory protection, and it's believed that that's why healthcare personnel were at such high risk of COVID-19 at the start. Once we suspected that there was human-to-human spread of COVID-19, then we still continued to see healthcare workers getting infected with COVID-19. But when they did the investigation with that second set of healthcare personnel, what they found was that the vast majority of them had a household member who was infected with COVID-19. So it was highly probable that they were actually exposed to the disease in their house as opposed to in the hospital setting. So we don't at this time know the exact risk to healthcare personnel of taking care of COVID-19 patients. But again, historically, healthcare personnel are at higher risk from these infectious diseases during these kinds of events compared to the general public. So let's now talk about respiratory protection and masks. So respirators are considered to be respiratory protection, which is separate from wearing a mask for healthcare personnel when they're taking care of patients in a healthcare setting. Respirators are, from a scientific standpoint, more protective than surgical masks in terms of the occupational risk for a healthcare personnel wearing that piece of equipment. N95 respirators are the typical type of respiratory protection worn by most healthcare personnel in US hospitals and even in non-hospital healthcare settings when we have an individual that we believe has an airborne spread disease. NIOSH actually certifies respirators. They do testing on the respirators in their lab to make sure that they meet the standards to say that that particular brand of and model of respirator is NIOSH certified. And US hospitals are required by OSHA to use a NIOSH certified respirator in their hospital or healthcare setting. Masks, on the other hand, are not considered to be respiratory protection. So they do protect the wearer from exposure to respiratory droplets, but not to airborne spread particulates. And they are not certified by NIOSH. Instead, they are FDA approved. So they are two different levels of protection for healthcare workers. It is important when you're talking to healthcare workers that they not get sort of hung up on the shape of that piece of equipment to tell them whether or not it's a mask versus a respirator. What I've heard in the past from healthcare personnel is when they receive masks or respirators from a local, regional, or even the federal stockpile, is that they look at the shape of it to help them decide whether that's a mask or a respirator. And that's a false way of looking at it because respirators are cone shaped because they have to have a very tight fit to the face, but not all N95 respirators are cone shaped, but most of them are. Most masks tend to be rectangular in shape, but not all of them, because you can also have a cone shaped mask. So again, it's not how it looks. The individual has to read the side of the box to make sure that if they are looking for an N95 respirator, that they are actually using a box of N95 respirators that are NIOSH certified and approved for use in hospital settings for airborne spread diseases. This is just a funny picture that was sent to me during the SARS-CoV-1 outbreak in 2003, where in the general public, many individuals wore surgical masks or homemade masks to try to protect themselves from the disease because they were very worried about SARS-CoV-1. And when they ran out of masks and homemade masks, individuals tried other ways to try to protect themselves from SARS-CoV-1, including just this amusing picture with this bra. But I just wanted to make the point that these types of things are obviously not considered to be respiratory protection and not going to be fully safe. Not that healthcare personnel would try to take this approach, but members of the general public should also not be using non-masks or non-respirators to try to protect themselves. It might give them a false sense of security. N95s are respirators. They are respiratory protection, and they protect against airborne spread particles, which are very tiny particles that can attach themselves to dust particles and travel very far distances in the environment. So because of that, you need to wear an N95 respirator to really filter out those really tiny particles. And it's really important that the respirator fit very closely to the face. And fit matters because if there are gaps between the individual's respirator and their face, then air can get in between the respirator and the individual's face, and then they could potentially be inhaling those airborne infectious particles. So fit matters, which is why in the United States, we require fit testing before healthcare personnel, for hospital personnel. Fit testing is not required of healthcare personnel in other settings like long-term care. But for hospitals, of course, we have to do fit testing, either qualitative or quantitative fit testing to ensure that the individual has a good fit for that particular N95 respirator. This has implications for disaster response, which we're going to talk about in just a moment. Facial hair can be an issue in terms of getting a good fit for an individual trying to find an N95 respirator that really fits their face closely. And so if there's too much facial hair between the individual's respirator and their face, it might not have a good fit to their face and they might not pass the fit testing test, so to speak. So the CDC released this graphic that shows the different facial hairstyles and how an N95 respirator would fit on that individual's face. It's also a little bit amusing. I love some of the names that they came up with for some of these facial hairstyles. I thought it was really interesting. Some descriptions that I had not heard before in terms of different kinds of facial hair. But you can use this in your hospital when you are talking to individuals that do have facial hair about the types of styles that they can use when they have to wear respiratory protection and the kind of facial hair that would not be allowed when they need to wear an N95 respirator to protect themselves. So it's really important that individuals not only have the correct personal protective equipment, in this case, we're talking about respirators, but also that they wear that respirator correctly. So on the left-hand side, we've got a cartoon from Gary Larson from The Far Side, one of my favorite cartoonists ever. And there's two men in the jungle, obviously, and the one man says, "Wait a minute, McAllister, you fool, this isn't what I said to bring," because he brought the on instead of the off. So it's important that we have and we provide for our healthcare personnel the correct personal protective equipment to make sure that they're protected from occupational exposures. And then in addition, we also have to make sure that they're trained on how to use that appropriately. What we found during the SARS-CoV-1 outbreak, when there was such a large number of healthcare personnel that became infected with SARS-CoV-1, is that they had access to personal protective equipment, including N95 respirators. And in addition, they were actually wearing full PPE. They had an isolation gown, double gloves, eye protection, in some cases, a hair bonnet, and even booties. And there were still some healthcare workers who were becoming infected with SARS-CoV-1. And so the question became, do we need a higher level of respiratory protection, or is something else happening? And when we did observational and epidemiological studies, what we found is that the healthcare personnel were accidentally auto-inoculating themselves. In other words, they were removing their PPE, their respirator specifically, incorrectly and accidentally exposing themselves to SARS. So the way that they were doing it at the time was to remove the respirator either from the front or the side of their face rather than holding it from the straps. So the correct procedure when you are putting on and taking off an N95 respirator is to hold it from the straps and remove it from the straps on the back of your head and avoid touching your face as you're removing that respirator. So don't let your hands touch your eyes, your nose, or your mouth, because that is how we believe that they were potentially exposing themselves by incorrectly removing that respirator. Masks and respirators during routine times are considered to be single-use equipment. So individuals, healthcare workers should put on that mask or that respirator, go into a patient's room, provide patient care, and when they come out, then they need to discard that and select a new mask or respirator the next time they go into that patient's room. The only exception to that would be if a healthcare worker in the middle of providing their care duties, if something happens to their mask or respirator and it loses its integrity. So for instance, if somebody's taking care of an Ebola affected patient, and if that respirator became saturated with bodily fluids, then that would be a loss of integrity for that respirator. And that healthcare worker should then leave the room immediately and get a new respirator to put on before going back into that patient's room. But in general, masks and respirators are single use, meaning single encounter with a patient. But this issue of Ebola and masks or respirators is really important because there is a scientific study that found that when a respirator becomes saturated, and they also looked at masks, so if a mask or respirator becomes saturated with bodily fluids from an Ebola affected individual, then that does put the healthcare worker at risk because Ebola has been found to be able to survive for about 72 hours inside of a saturated mask or respirator. So not just if the front of the mask or respirator is wet from those secretions, but if it actually saturates all the way through. So this has important planning implications if we're planning for a future Ebola event. So when we look at what might happen during a future infectious disease disaster, we anticipate that we're not going to have enough PPE to go around. We're probably going to run out. When we look at what happened during H1N1 in 2009, that's exactly what happened. There was a study, a nationwide study that was done with US hospitals, even before we had a single wave of patients. But there was a lot of fear and concern, and there were a lot of worried well individuals showing up at US hospitals, and we were using a lot of PPE, much more than we would use during routine times. And what that study found was that 35% of US hospitals reported running out of N95 respirators before we had the patient surge. So that really shows how very quickly we can run out of PPE. And when we start to run out of PPE, it has occupational exposure risks for that healthcare personnel. It's been estimated that if we had another pandemic that was similar to the Spanish flu pandemic of 1918, that several billion N95 respirators would be needed for US healthcare personnel to respond to that event. And we just simply do not have enough disposable N95 respirators to accommodate that kind of an event. The SNS, or the Strategic National Stockpile, the federal stockpile, of course, was deployed during the H1N1 pandemic, and it did release respirators to US hospitals, or to many US hospitals. But a study that was conducted with US hospitals found that when the SNS was deployed, it was not deployed consistently across US hospitals, and it actually created, in some ways, challenges for US hospitals. So many individuals that worked at hospitals reported that they would receive all of one size of respirator. So for instance, they might have received a 3M or Kimberly-Clark N95 respirator, but they were all size small. And that did not allow their healthcare personnel that needed other sizes to be able to wear those respirators. So that created some differences in terms of access to the PPE across the United States. There was also the issue of the brands that are stockpiled in the SNS versus the brands that are typically used by US hospitals. So US hospitals do fit testing using the brands that they purchase for routine use, of course. But when the SNS or even when local stockpiles were deployed to US hospitals and it was a different brand that arrived, that required them to refit test all of their healthcare personnel. And so that creates a real issue because you have to do all that fit testing. It's very time consuming and very expensive. So sort of like the guy who's in the desert and he shows up on the crashed plane and all he finds are sweatpants. We might end up getting the wrong kind of supply that we don't necessarily need or that isn't the best fit for us during a disaster, and we need to build that into our plans. Now, this is a little late for COVID-19, of course, but keep in mind this is also a planning document or planning webinar for future events. There was a study that was conducted, I believe in 2009, that gave estimates for PPE stockpiling for future pandemics. And the thing that's important for the webinar that I'm giving today were the recommendations related to stockpiling of respiratory protection for US hospitals for a future pandemic. So they divided their recommendations based on the number of staff at each hospital or healthcare facility that has little to no exposure to patients, individuals that are expected to have prolonged exposure to patients, and those that have infrequent exposures. And so they laid out how many respirators and types of respirators for each of those individuals would be needed. So you could use these planning guidelines to determine how many healthcare personnel you have that you anticipate having prolonged exposure to an individual infected with the disease in that pandemic, and that they recommend, in this case, one reusable respirator per outbreak, plus additional cartridges in order to allow you to use that reusable respirator, which I'm going to talk about in just 1 minute. But for individuals that have little or anticipated to have little or no exposure to individuals infected with the disease during that pandemic, then for those individuals, you might plan to use disposable N95 respirators instead. So again, you can use these estimates to come up with an estimate of how much PPE, respiratory PPE, needs to be in place before a future event occurs. In addition to PPE and respirators that are used by healthcare personnel during these infectious disease disasters, what we've seen historically in other countries is that members of the general public have also chosen to use masks or respirators to try to protect themselves from community spread of disease. The picture on the right with the cute little ballerinas all wearing masks, that picture was taken during SARS-CoV-1. And if they had shown a picture of the audience with the parents all watching their adorable little ballerinas, they would also all have been wearing respiratory protection because masks and respirators were used by members of the general public in Southeast Asia during response to the SARS-CoV-1 outbreak. It was considered during the H1N1 pandemic, including in the United States, there was discussion about whether or not the general public should be wearing masks or respirators to try to prevent community spread disease, which then led to some funny cartoons such as the one you see on the slide, joking about whether or not individuals needed to take gloves and respirators with them when they went on vacation that summer when the pandemic first started. What we've seen so far in COVID-19, at least in China, is that many individuals did choose to wear masks or respirators in the general public. So again, these are non-US based recommendations, but they are practices that we've seen in other countries. And this does have an impact on supply chain and access to respiratory protection for the United States, because we do import some of our PPE from China and from other countries. So if members of the general public have access to that PPE, we might not be able to import it to the US. What we've seen so far for the US general public's response to COVID-19, and I'm sure you've seen this on the news, is that many individuals in the public have chosen to stockpile masks, hand sanitizer, and inexplicably toilet paper. I'm not sure exactly what that's about, but it has led to some sort of interesting discussions about what individuals should be stockpiling and planning for to respond to COVID-19. But right now, the United States is not recommending that the general public wear masks or respirators. Those individuals are not trained on how to use and wear masks and respirators appropriately, and it can give them a false sense of security. In addition, it also takes that supply away from us being able to provide that to our workers, our healthcare personnel who are really high risk. So it is not recommended that members of the general public purchase or use masks or respirators for COVID-19 at this time. So in planning for having access to respiratory protection and how we respond during infectious disease disasters, there are three kinds of surge capacity specific to respirators. There's conventional capacity, which is our routine practice of how we use masks and respirators in healthcare settings. There's contingency capacity, which might be minor changes in daily practice, but they don't have an impact on the care that's actually provided to those patients. And then lastly, there's crisis capacity, also known as crisis standards of care, when we have plans and policies in place where we alter our standards of care in order to be able to conserve the number of respirators that we have so that we can prioritize those for healthcare workers who are at very high risk. So I'm now going to talk about two different crisis standards of care that are available specific to respirators. One is very broadly speaking for all infectious disease disasters. And then secondly, I'm going to talk about the CDC's specific respirator altered standards of care or crisis standards of care that the CDC has released related to COVID-19. Before I do that, I want to do a quick poll. So Christy, if you could please pull up the question related to altered standards of care. So if you could please answer whether your hospital or healthcare facility currently has a crisis standard of care policy related to respirator usage. Okay, so everybody hasn't voted, but it looks like it's kind of tied. So it looks like about a third of you have that. But the rest of you either don't have a crisis standard of care related to respirator usage, or you're not sure if you have that. So let's talk about the existing policies or the existing templates that can be used to help you create a crisis standard of care that's specific to respirators. Okay, so we'll start with, oh, I mentioned before, so APIC has, let me go back. APIC, the Association of Professionals in Infection Control and Healthcare Epidemiology, has created a crisis standard of care template for US facilities that can help you develop a policy related to extending the use or reusing respirators in healthcare settings during infectious disease disasters. And this is not specific to any particular kind of disaster, except that it's specific to any disaster that's going to exceed the number of respirators or respiratory protection that we need for our healthcare setting, which is primarily infectious disease disasters. And then secondly, the CDC has released a set of guidelines related to how to optimize our current supply of N95 respirators specific to COVID-19. So this set of guidelines looks a little bit different from the APIC guidelines, and I'm actually going to be talking about both of them. I would say about 90% of the guidelines match for both of them, what APIC is saying about all disasters in general and what the CDC is saying about this particular event with COVID-19. So there's a lot of overlap and a lot of things that they have in common. There are a couple of places where they differ, and we'll talk about that as well. So the first step is to try to conserve the N95 respirators that we have by reducing the number of healthcare workers who actually need respiratory protection. So one way that we can do this is by cohorting patients. What that means is that we put all of the individuals that are known to be infected with the same disease, in this case, COVID-19, into the same room or the same area so that we then are able to, in addition to cohorting the patients, also cohorting staff. Cohorting staff means that a limited number of staff are assigned to those areas that are taking care of those individuals who are infected or believed to be infected with that particular disease. This reduces the number of staff in a hospital overall that are going to be exposed to individuals that are infected with that disease. And it limits the number of healthcare workers that have to have respiratory protection while they're working in the hospital. Another way to conserve your supply of respirators is to implement a telemedicine or nurse triage lines, some sort of virtual triaging and care for individuals where you can assess whether or not they actually need to come to the hospital to be provided care. Because when you're doing virtual assessments, then the individual, the healthcare worker, obviously does not need to have on respiratory protection. So that can help conserve the respiratory protection for individuals who are providing face-to-face care of potentially contagious individuals. Another way to conserve the supply is to reserve, in particular, the N95 respirators for healthcare workers who are performing aerosolizing procedures. Aerosolizing procedures are those that have a tendency to cause infectious aerosols when you're providing that particular care. So for instance, open airway suctioning or intubating or extubating patients tends to cause a release of aerosolized infectious particles, placing those healthcare personnel at higher risk of exposure. So when healthcare personnel are doing an aerosolizing procedure, they should be prioritized to receive N95 respirators over other individuals that might be only given a mask when they're providing standard routine care of infected individuals. Another way that you can conserve your supply of N95 respirators or just of PPE in general is to restrict the number of visitors that are allowed into your facility. Restricting visitors allows you to not need to give that mask or respirator to the visitor who also needs it when they are going in to visit somebody who has that particular disease. And that way you are conserving it to use with healthcare personnel. Visitor restriction policies have been shown to be very effective at reducing the amount of spread of disease, preventing the visitor from bringing the disease into your hospital and also preventing that visitor from becoming infected while they're in your hospital or in your healthcare facility. Now, one caveat here is that pediatric hospitals tend to have different visitor restriction policies, and they tend to be a little bit looser because we have found that research indicates that it is very important for when you're providing care to pediatric patients that they do have access to their parents and guardians and other close family members. So visitor restriction policies might not be the same at all US hospitals, and you need to look at your patients and your supply of respirators and try to make your decisions based on that. There are also one of the best ways to conserve especially your disposable N95 respirators and also protect your healthcare workers is to have on hand reusable respiratory protection. So as I said before, most hospitals use N95 respirators, which are considered to be a single-use piece of equipment, but there is also respiratory protection that can be reused with multiple patients. And two examples of those there are two types of reusable respiratory protection. There are PAPRs and then elastomeric respirators. PAPR stands for Powered Air Purifying Respirator. These are loose-fitting hoods or helmets that also have a blower that pulls air through usually a HEPA filter so that the healthcare worker is not being exposed to infectious particles. These do not require fit testing because they just fit very loosely over the head, over the entire head. And the advantage is they can be worn with people regardless of the type of facial hair that they have. Now, a disadvantage to PAPRs is that they're very expensive and it's difficult to use a stethoscope when you have one on. So there are some limitations to PAPRs. In addition, PAPRs are not supposed to be used in the OR or any surgical setting because the blower exhaust and exhaled hair can actually contaminate the sterile field. Elastomeric respirators consist of either a half or a full face respirator that's made up of either some kind of synthetic or a rubber material of some kind. They usually have filters on them and it can block different levels of small particulates. It can either be 95%, 99%, or 100% coverage in terms of protecting you from those particulates. So that means that the elastomeric respirators are actually more protective than N95 respirators. They can be reused in between patients, as can be the PAPRs. But there can be some communication difficulties with individuals wearing these elastomeric respirators. They also cannot be used in the OR setting. Both PAPRs and elastomeric respirators can or have to be decontaminated between usage. Even though they are reusable, you have to make sure that you are decontaminating them so that the outsides remain safe in order to be handled. And so we just follow the manufacturer's recommendations on exactly how to decontaminate each piece of equipment, because there are different recommendations for each piece of equipment. They're also very expensive, so it's important as sort of a future disaster planning guideline to try to have at least some reusable respirators or respiratory protection on hand, and use those for the staff who have been cohorted to provide care to the infected individuals. And that can cut down on the number of disposable respirators that you need to have on hand. So in the long term, it can actually save your hospital or healthcare system money, because even though it costs more to purchase this equipment up front, it's reusable, so you're not constantly replacing it. There is some minor cost in replacing some of the cartridges and filters that come with this equipment, though. In addition, a relatively, well, actually, this is a brand new, as of last week, recommendation from the CDC, is there's a new way to obtain extra N95 respirators during an infectious disease disaster. And that is using N95s that have been stockpiled that have actually gone past their expiration date. So those of you that are familiar with the SNS, the Strategic National Stockpile, and the rules related to how we govern which medical countermeasures can be used, you are probably already familiar with the concept of the shelf life extension program. So the shelf life extension program for medical countermeasures says that medical countermeasures can be used past their expiration date if they're part of the federal stockpile. And they've done that because they've done testing on the stockpiled MCMs, and they have found that some medical countermeasures maintain their efficacy even past the expiration date that was listed by the manufacturer. Now, prior to a week ago or so, whenever the CDC made this change about respirators, the shelf life extension program did not extend to any other medical equipment. It only applied to MCMs and not vaccines either. But because the CDC was anticipating a shortage of N95 respirators across the United States if COVID-19 really starts to expand and really starts to have a very large patient surge, the CDC did some testing with stockpiled N95 respirators to see if they were still safe and effective even though they had expired. So NIOSH went to 10 different stockpiles across the United States, and they chose 11 different models of N95 respirators, all of which had already expired. They had been manufactured during a 10-year time period of 2003 to 2013. They took those N95 respirators, those expired respirators, into the NIOSH lab, and they tested them the way that they test new respirators to see whether or not they were safe and effective for use. And what they found was that a lot of those N95s still met the NIOSH standards. So the CDC then released guidelines that said, okay, so for the N95 respirators that passed the NIOSH testing, it's okay to use those even though they have expired, but only this is specific to the COVID-19 outbreak. Now, that being said, now that we have done this for COVID-19, it's very likely that this same practice will be used if we have a future infectious disease disaster, but it's not currently built into the pandemic planning guidelines for future events. So this is a very specific COVID-19 response that the CDC is choosing to follow. So there's my little caveat. So again, I'm going to go back to my original disclaimer. Always make sure you check the CDC website to make sure you're following the current guidelines for whatever event is happening, because these things do change very, very rapidly. So on the slide, I have listed on the left-hand side in green were the the safe models of the respirators that were tested by NIOSH. So the CDC has said that these models of respirators can be used even though they have expired. And on the right-hand side were two types of respirators that did not fully pass the test done by NIOSH. Those are considered to be questionable N95 respirators. So if your hospital has access to a local or regional stockpile and there are expired N95 respirators in that stockpile, you should check the models against the CDC information to see if you could still use those safely with your healthcare personnel. And this can provide you a little bit of cushion in terms of having access to extra N95 respirators as we respond to COVID-19. But there's a tiny caveat with that. So if your hospital does have access to these expired N95s that have been approved by CDC for use during COVID-19, when healthcare workers obtain those expired N95s, they need to know that they are using one of the expired N95s because there are special procedures that they need to follow. The CDC has said that even though they tested some respirators from those lots of respirators that were in those 10 stockpiles nationwide, they obviously did not test every single respirator in every single stockpile to make sure that they were all safe and effective. So they recommend that healthcare workers visually look at that respirator before they put it on when it's expired. And there are two things they should check. One should be the straps and make sure that the straps are still connected and kind of pull on them and make sure that they don't seem as though they're brittle and going to break once they put it on and once they're wearing it in the patient's room. And then secondly, the healthcare worker should look at the nose or the bridge material, which is made out of foam. And if there is breakdown of that foam, then that N95 respirator should not be used and it should be thrown away. The longer an N95 respirator has been stored, especially if it's been stored in a non-temperature controlled environment, there's the likelihood or at least the possibility that the N95 respirator could have broken down and may not be as effective. So it is really important that the healthcare worker test that and look at it to make sure that it looks okay before they put it on. In addition, once they put it on, as they should with any respirator, that they should perform a user seal check to make sure that it actually has a tight fit to their face. Then there's one other caveat. The expired N95 respirators are not to be used for staff that work in the OR setting. So OR staff need to be prioritized for new N95 respirators, according to the CDC. So if you're in a situation where you're starting to run out of N95 respirators and you've even accessed those expired respirators and it still looks as though you're starting to run out, then what our altered standards of care, our crisis standards of care policies indicate is that then you should have staff switch to an extending the use of the respirator procedure. Extending the use of a respirator simply means that instead of putting on a respirator, going into that patient's room, taking care of one individual, coming out of the room and then throwing it away, the healthcare worker would put on that respirator and they would wear it for an extended period of time without taking it off. Meaning they might provide care to that same patient multiple times, or they might even provide care to multiple patients before they take off that respirator. So they could potentially wear that respirator, probably not an entire shift because they would need to stop and get something to eat or drink, or they might need to take it off because they feel uncomfortable, which I'll talk about in a minute. But they could wear it for an extended period of time, however long they feel comfortable wearing that respirator. When you have an extending the use policy, once you take off that respirator that's been worn for an extended period of time, it needs to be thrown away. In addition, like with all respirators, if somebody is wearing that respirator and it becomes soiled or damaged or there's a loss of integrity in any way, it should be immediately removed and you should put on a new respirator. Next, if you are still starting to run out of respirators, despite the fact that you have brought in your expired respirators, you've been extending the use, you're still running low, then the next procedure to implement would be the reuse of respirators. So the CDC indicates that respirators can be reused up to a certain number of times, depending on the event. Reuse of a respirator is different from extending the use. With reuse of a respirator, it means that an individual would put the respirator on, take care of patients where, for multiple patients, they would basically extend the use. And then when they were ready to remove that respirator, instead of throwing it away, they would actually store it and they would redon it later when they need to put a respirator back on to go back into a patient's room to provide care. This is known as limited reuse of a respirator because you're not allowed to simply reuse a respirator for unlimited numbers of times. Currently, the CDC restricts the number of times that a respirator can be reused. In other words, the number of times it can be put on, worn, taken off, and then redonned. So the current recommendations are that the number of times a respirator can be reused depends on the manufacturer's guidelines, which will tell you how long that particular model of respirator can be reused, or 5 reuses. So those are the guidelines, manufacturer's guidelines or 5 reuses. It's also really important when you have a reuse of respirator procedure that the staff not share the respirators. So it's just one respirator per person, not that Susie would wear it and then John would wear it next. From a planning standpoint, extending the use of a respirator is preferred over reuse because reuse of respirators has a slightly higher risk of exposure for healthcare workers than extending the use. So when you are using a reuse of respirator procedure or policy in your hospital, the respirator has to be stored between uses. So healthcare personnel should be instructed to either hang that respirator in a designated area or store it in a designated area in some kind of clean, breathable container. And it should be by itself in that container. So one common way is to just simply use brown bags like I've shown here on the slide. And that way it's clean, it's dry, it's holding that respirator, and it's not getting exposed to other things in the environment. But you don't want to put anything in, on, or around that respirator while it's being stored. So in other words, you don't want to wrap it in newspaper or in a Ziploc baggie or anything that tight. You want it just by itself in its container. And then before it's redonned, you need to perform a user seal check, as we do with all respirators. When you're reusing or when you have a reuse of respirators policy, it's really important that the healthcare personnel write their name on the straps and also on the container to again make sure that individuals aren't accidentally sharing respirators between uses. It needs to be assigned to one healthcare worker, and they should keep reusing that respirator until the number of uses has been exceeded. Then they throw it away and get a new one. So the current recommendations about reuse of respirators specific to SARS-CoV-2 or COVID-19, which was true as of last night, is that you can implement a limited reuse of respirators policy up to 5 uses per respirator. Now, the reason why the CDC is currently recommending only 5 reuses of respirators for COVID-19 is that we're lacking evidence about exactly how COVID-19 is spread. So we currently believe that the primary route of transmission is respiratory droplets. However, there's a little bit of evidence that it might be also spread through direct and indirect contact with the environment. So because there's that potential risk of contact transmission, that means that the outside the respirator is potentially contaminated, and it might pose a risk to the healthcare worker simply by putting it on and taking it off because their hand's going to be on that contaminated respirator. So because of that potential risk, again, they're limiting it to 5 reuses, and they recommend, as always, when the healthcare worker takes that respirator off, they need to perform hand hygiene before they touch their face to make sure they're not accidentally auto-inoculating themselves. Another way that you can implement policies that can help extend the use and reuse respirators and have access to respirators for your highest risk staff during these events is to prioritize which staff are actually going to receive the respirators. So the top priority should be healthcare workers who are providing patients who are on airborne isolation. So that might include your TB patients that are hospitalized, if it's a smallpox bioterrorism attack, smallpox patients, SARS-CoV-1 was considered to potentially be airborne, and so they did recommend N95 respirators for that disease, or any other airborne spread disease, or that's believed to be airborne spread. The second option is to use or prioritize those N95 respirators for aerosolizing procedures, as I mentioned earlier, and I have those listed on the slide. But it's really any procedure that's going to potentially cause an aerosol of infectious particles. And then lastly, you would want to prioritize your healthcare workers to receive respirators if they themselves are at high risk from that disease, meaning if they're at high risk for complications or death if they were infected with that disease. This last recommendation is very event specific because high risk staff for instance, COVID-19 might be different than our high risk staff for another event. If it's an influenza pandemic, you have to look at the epidemiology of each event to determine who are your high risk staff, and they should be prioritized to either receive N95 respirators or better yet, not even be assigned to those areas where contagious patients are located. The Institute of Medicine released some guidelines related to this idea if we're going to have an extended use or reuse of respirator policy in place during pandemics, there might be a better way to help, or an additional way to help reduce the occupational risk to healthcare workers. And so what they recommended was that in addition to wearing an N95 respirator, if you put a surgical mask on top of that respirator, it's protecting that N95 respirator from external contamination. And so that way the mask is getting contaminated by the infectious particles being released from the infected individual. So that means that if you had a mask on top of the respirator while you're taking care of that patient, once the healthcare worker left the room, they could remove the mask and throw that away and get a clean mask to put on top. But it keeps that respirator, it reduces the bioburden on top of that respirator and potentially protects that healthcare worker more from a possible occupational exposure. Now, the CDC pandemic planning guidelines, and these are different from the COVID-19 response guidelines that are currently being released. So I just want to make sure I'm differentiating here between what the CDC has in terms of their planning recommendations for a future influenza pandemic versus what's actually happening right now and what they're recommending for COVID-19, because they are different recommendations. So for their pandemic planning guidelines, the CDC says that N95 respirators, even when you're reusing them, if you have a reuse policy in place, they still have to be discarded anytime a healthcare worker performs an aerosol generating procedure, if it becomes contaminated with bodily fluids, or if that patient has an organism that's spread by the direct and indirect contact route. And they say that there are two ways to protect the respirator. One would be to put a surgical mask on top, the way that IOM had first recommended. Or a second option, according to the CDC, is that you can have a face shield on top of that N95 respirator. And the thinking is the same. It's protecting that N95 respirator from becoming contaminated. And the face shield can either be disposable and you throw it away and get a new one, or you can use a cleanable face shield that can be decontaminated in between patient uses. Now, again, I'm differentiating their pandemic planning guidelines that I just talked about from what they're saying about COVID-19. So as of yesterday, when I checked the CDC website, they're saying that you should not do this, that you should not, you don't need to put a surgical mask on top, you don't need to use a face shield on top. And they're saying this because there's a potential risk of contact transmission, like I said before, or at least I'm assuming that that's the reason why they are not using their pandemic planning guidelines for what they're currently recommending for COVID-19, because the two sets of guidelines do not currently match. If, and I hope this doesn't happen, but if you were to reach a point where your respirators are completely depleted in your hospital or your healthcare system, then, and that includes if all of your expired N95s have also been used, then the CDC recommendations and the APIC recommendations for long-term use of respirators says that the next best thing is to use a non-NIOSH certified N95 respirator. So outside of the United States, healthcare workers and hospitals, they use N95 respirators that have not been certified by NIOSH, obviously, because NIOSH is a US-based organization, but they use other criteria to certify that their N95s are safe to be used for healthcare personnel. So the CDC has said that you could use, those would be like the next best thing to use if we run out of our N95s that are certified by NIOSH in the United States. They also recommend that you exclude your high-risk staff from providing care to infected patients at that point. So in other words, if we run out of N95 respirators, if we have to use another type of respiratory protection, the high-risk staff for that event should not be providing care to patients that are contagious. And again, as I mentioned before, this is very specific to that particular event. So for instance, for COVID-19, the current high-risk groups are the individuals that we believe are the highest risk for severe complications and death, include the elderly, individuals that have a chronic medical condition, and pregnant women. This might look very different during an influenza pandemic or a different outbreak of an emerging infectious disease. So again, you always have to look at what the current epidemiology is and what the CDC is currently recommending. If you completely run out of N95 respirators, then the CDC and APIC recommend having healthcare personnel use a surgical mask. But not all procedure and surgical masks give equal protection, because it depends on how closely it fits to your face. So the recommendation that's been made by APIC is that it would be better in that situation to choose surgical or procedure masks that tie behind the head, so you could tie it a little tighter, versus the ear loop masks, because ear loop masks tend to be a looser fit. Now, I realize that some hospitals might not have a choice about what kind of masks you have access to, but this is just one of those planning recommendations that if you have a choice, it would be better to go with a mask that ties versus an ear loop mask. Then, if the situation becomes even more dire, if you have run out of N95 respirators and you don't have reusable respirators, and you've run out of surgical masks, then the next best thing to provide to your healthcare staff would be full face shields that would at least provide some protection against respiratory droplet and airborne spread diseases, or FDA cleared respirators that are available for the general public. That would include respirators that you could find at hardware stores, Walgreens, and Amazon, for instance. Not right now during COVID-19, because right now you can't get a hold of masks or respirators anywhere outside of healthcare vendors. But in general, usually you can find FDA cleared respirators for the general public in most hardware stores and Walgreens and other kinds of outlets. You could also go to a cloth or a woven mask or a dust mask. Now, obviously, if we are reaching the point in healthcare where we've run out of N95 respirators, we don't have reusable respirators, we've run out of surgical masks, and what we are now providing our healthcare workers are simply face shields, FDA cleared respirators, or cloth or woven masks, these are not fully protective for healthcare staff. That's why this is part of an altered standard of care or a crisis standard of care. So we would never do this during routine times when we have access to respiratory protection. You have to keep in mind that all of this is very specific to events where it's a catastrophic event, large patient surge, and we have just run out of respiratory protection to protect our healthcare staff. So these are not the best case scenarios, obviously. So let's now talk about, let's assume you actually have access to respiratory protection and healthcare workers have to be wearing that respiratory protection throughout that infectious disease disaster. If you think back to earlier when I mentioned that we could be talking about a 6 to 8 week or potentially even longer wave of patients, this could mean that healthcare personnel actually have to wear a mask or respirator for their entire shift or close to their entire shift, multiple shifts in a row for multiple weeks and potentially even for months. The picture that you see on the slide was a picture taken in a Canadian hospital during the SARS-CoV-1 outbreak where they were having a staff meeting doing an update on the event. And as you can see, all of the healthcare workers are wearing their respiratory protection. those individuals wore that respiratory protection from the time their shift started until their shift ended, and they only removed it when they needed to get something to eat, something to drink, or they just needed a break from wearing that respirator. Now, both anecdotal and our research information has taught us that this can be really challenging for healthcare staff to wear this respiratory protection for a long period of time. So let's now talk about what happens when individuals are wearing respirators for long periods of time and what that does for compliance and what that might mean to their occupational risk. When it comes to looking at the research related to how compliant and how tolerant healthcare workers are related to respiratory protection, the data has found to be very, very conflicting. So for instance, there was a study conducted in China that found that the healthcare staff were relatively compliant. They had between 68 and 76% compliance over a 4-week time period where they needed to wear the respiratory protection for their entire shift. A study that was conducted in Australia only found 30% compliance for that same 4-week time period. In the United States, studies that were conducted found that there was less than 60% compliance with respiratory protection during the H1N1 pandemic. So you can see it's different across different countries in terms of the actual compliance rate with which healthcare workers are able to tolerate and be willing to wear respiratory protection. So researchers have asked the question of, why are the healthcare workers not being compliant? Is it because they're uncomfortable, or is there some other factor that's going on? So how could we intervene to make this easier for them so that we can increase the amount of compliance? Because our ultimate goal, of course, we want to protect our healthcare workers. We don't want them to get infected. We want them to feel safe and willing to come into work to take care of the patient surge. So there was one study that asked healthcare workers why they were non-compliant wearing masks and respirators, and 30% said that they felt they had difficulty breathing when they were wearing an N95. And 56% said that their face felt very hot and they got very uncomfortable wearing that respirator for any length of time. Another study looked at PPE comfort and asked staff how the extent to which they felt like PPE was actually affecting their ability to do their job. And what they found was that almost half, it was under half, 42%, said that PPE does affect their ability to do their job. And as you can see on the slide, the biggest bothersome PPE that was identified by those healthcare workers was the mask or respirator. 70% of the healthcare workers said that the PPE that most affects their ability to do their job is the need to wear a mask or a respirator. There was a study conducted in 2015 that found that fewer than 15% of healthcare workers actually wore the Ebola-specific PPE correctly. So there was very low compliance with PPE specific to the Ebola crisis. And then they actually did a follow-up study where they intervened and they did extensive training with healthcare personnel and medical and nursing students. They gave them 3 different training sessions on the Ebola-specific PPE. And what they found was that even after those 3 training sessions, only half of all of the medical and nursing students were making very critical errors when they were taking off their PPE. What that means is that they could be potentially auto-inoculating themselves and becoming infected because they are accidentally removing their PPE incorrectly. So PPE compliance can have a couple of different factors related to it. It can be related to discomfort. It can be related to knowledge about how to put on and take off that PPE correctly. There are a number of different factors that might be involved here. There's also some physiological effects from simply wearing respirators. So when I worked in infection prevention at a hospital for a healthcare system, when I would talk to healthcare personnel, what they would tell me is that the N95s in particular were very uncomfortable. They didn't like wearing them. And in their perception, they had difficulty breathing, that it was hard for them to breathe while they were wearing that N95 respirator. When you actually look at the data from NIOSH about the actual physiological effects of respirators, to me, it's this very interesting data. So N95 respirators can actually be called negative pressure respirators because as you're wearing one, as you're inhaling, there's a slight negative pressure that's actually created inside that face piece. And this creates this slight increase in the work to breathe. And it does put some strain on the wearer and the need to overcome that resistance of that N95 filter. So in other words, it is slightly harder to breathe while you're wearing an N95 respirator. And this leads to this inspiratory resistance. Over time, as you're wearing that N95 respirator, that resistance will increase a little bit because the respirator will start to retain organisms, particles, and also just some exhaled water vapor from the person wearing that respirator. And as that resistance increases, then you're able to draw less air through that respirator. And so that can create a slight increase in the expired CO2 due to wearing that respirator. And not all of the air that's actually breathed into that respirator actually goes into your lungs. And not all the air that you're expiring while you're wearing a respirator actually leaves the respirator. Some of it stays inside what is called the dead space inside that respirator. And that can have varying levels of both oxygen and CO2 levels that are constantly being rebreathed while you're wearing that respirator. So that's kind of the physiological information about what happens when you're wearing an N95 respirator. So OSHA has some limits about, or some guidelines about the extent to which, or the limits to which individuals can be exposed to CO2 levels and also oxygen deficiency. So in other words, OSHA says that we have to protect our healthcare personnel from hypercapnia or hypoxia, because if you have hypercapnia or hypoxia, the healthcare worker can then have headaches, fatigue, dizziness, nausea, mental status changes, and actually altered performance. Now, however, that being said, the studies that have been conducted by NIOSH in their lab have shown that CO2 and oxygen levels are not negatively affected by wearing N95 respirators. Now, the NIOSH studies that have been published involved young, healthy subjects that would walk on treadmills as a way to try to replicate what would be happening in a healthcare setting with healthcare personnel. Obviously, there are some limitations there, right? Like a young, healthy college student who's wearing a respirator walking on a treadmill is not the same thing as a healthcare worker who might be in their 50s or 60s. Maybe they're overweight, maybe they have some comorbidities, and they're performing patient care duties, which can be stressful or strenuous. So my colleague, Dr. Ruth Carrico, and I conducted a study using actual MICU nurses to look at the physiological and psychological effects of long-term respirator usage. Because when the IOM first came out with the recommendations about putting a mask on top of the respirator, there was no science behind what would happen to that wearer from having that extra piece of medical equipment on top of that respirator. So we actually wanted to measure systematically what was happening to individuals when they were wearing an N95 alone, and also what was happening if they had an N95 with a mask on top. So for our study, we followed a number of MICU nurses for 2 different 12-hour shifts. And in one shift, we had them wear just an N95, and in some shifts, they wore an N95 with a mask on top. And we randomized, so some patients or some of the staff would start with the N95 and mask combo, and others would start with the N95 alone. So we tried to cut down on some of the bias there. And then the nurses, and they were very gracious about this, we checked them every 30 minutes of their entire 12-hour shift. We checked their blood pressure, their heart rate, their CO2, and their oxygen levels, and to check to see exactly what was happening physiologically with them as they wore this respiratory protection for a long period of time. In addition to the physiological variables that we assessed, we also asked them some qualitative questions related to respirator comfort, for instance. How comfortable was this? And then there were also questions related to how hot it was and how well they were able to tolerate wearing that respirator. So there were a number of different qualitative scales that we had them answer about how they felt about wearing that respirator for that entire 12-hour shift. In addition, we also observed their practice. So as they were wearing this respiratory protection for their 12-hour shifts, we actually watched them to see how many times they readjusted the respirator on their face, how many times they touched the respirator, how many times they touched their face, how many times they actually reached under the respirator to get a finger inside, because what we would hear them say is they needed some fresh air. So they would hook their finger into the respirator, kind of slide it a little bit, take a deep breath, and then put the respirator back in place. And then we also count the number of times that they touched their eye while they were wearing the respirator. So this relates to respirator compliance, because if you're adjusting that N95, if you're touching it, especially if you're going under the respirator and moving it, you are potentially exposing yourself to infectious particles, because you are getting potentially contaminated air or a contaminated finger inside near your mucous membranes that could expose you to disease. So the results from our study, what we found is that 90% of the nurses were able to tolerate the N95 or the N95 mask combo for both of their shifts. But there was one nurse that dropped after 30 minutes. Like, she just said, I can't do this. I can't breathe in this thing. There's no way I can tolerate this. And even though that's only one person out of the study, that is really significant, at least to me, because from a practice perspective, that says that there are going to be some healthcare staff that are not going to be able to tolerate wearing respirators for an entire 12-hour shift, and certainly not multiple shifts in a row. We calculated the number of N95 respirators that the nurses needed during this study. We did not have them reuse the respirator. They did use the extended use policy, so they wore it as long as they wanted to, and then we asked them before they took it off why they were taking it off. But once they took it off and threw it away, we had them take a brand new respirator. And on average, they used 3 N95s per shift. So that's still a large number if you calculate the number of healthcare personnel that would need to wear respiratory protection over a 6 to 8 week time period, and you multiply it by 3 individuals per shift. It's a lot of respirators. So even though this reduces the number that you need, it does not, you still have to have a very large stockpile in order to be able to accommodate the patient surge during an event. So as I mentioned, we asked the nurses before they took off the respirator, like, why are you taking this off? And sometimes they said they needed to get something to eat or drink. And sometimes they said they took it off because it was uncomfortable. So about a quarter of the time, 22%, they said that they took it off because the N95 or the N95 mask combo was uncomfortable. And some quotes that they told us as they were taking it off was, they said, it's getting hard to breathe, the N95 is uncomfortable, or I can't breathe. So essentially kind of all the same thing. They were uncomfortable and they felt like they just couldn't wear that respirator any longer. When we looked at the physiological data, here's to me where it got really interesting. So there were some significant negative effects on the individual from a physiological standpoint. CO2 levels did go up, statistically go up, but it wasn't clinically relevant. So it did not reach a point where their CO2 was so high that they were actually having symptoms. It just, from a statistical standpoint, did increase over time from wearing it. More importantly, or I guess maybe not more importantly, but there were other effects that they had from wearing that N95 alone. They reported more perceived exertion, so they felt more tired wearing that N95 by itself. They perceived that they were short of air or short of breath while they were wearing that N95 respirator. And they complained about headaches, lightheadedness, and difficulty communicating with patients. So next we compared it to the data for the individuals while they were wearing the N95 with the mask on top. And what we found is that there were significant differences over and above the negative effects from just wearing that N95 for extended periods of time. CO2 again went up more wearing the N95 plus the mask than just wearing the N95. But again, it was statistically significant, but it was not clinically relevant. So in other words, they were safe. They were fine from a physiological standpoint. But they also complained about more nausea and more visual challenges when they had the mask with the respirator on top. When we looked at the compliance data, what we found is that on average, there were about 26 times during a 12-hour shift that nurse was non-compliant with wearing their N95 or the N95 mask combo. This consisted primarily of touching the N95 and adjusting either that N95 alone or if it had the mask on top, adjusting that respiratory protection. But what we did find, and I thought this was really interesting, and this was not what we had anticipated, they didn't become less compliant over time. So going into the study, we thought that as the shift wore on and people got tired, that maybe they would become less compliant and start making more mistakes the longer they had the respirator on. But that is not the case. They were essentially non-compliant the entire shift. And it really didn't matter whether it was the beginning of the shift or the end of the shift. They were just, in general, a lot of non-compliant behaviors that we saw while people were wearing their respiratory protection. We also had this really interesting finding, at least interesting from my perspective, that the individuals, the nurses that were obese, had more significant negative effects from wearing the N95 or the N95 and mask combo compared to the nurses that were not obese. They had lower oxygen rates and they had higher heart rates. They reported more perceived exertion and more shortness of air. They reported more discomfort wearing that respiratory protection. They complained more about headaches, lightheadedness, visual difficulties, nausea, and more challenges communicating than the nurses who are not obese. And they actually touched their N95 respirator more often than the non-obese nurses, which I kind of think of as like a surrogate for their comfort. They were touching it and adjusting it because they were uncomfortable, or at least that's my interpretation of what was going on. So kind of summarizing everything that I've talked about, there are some long-term use of respirators, some planning guidance for developing future policies and future response during events. It is really important that we purchase some reusable respirators because that will reduce the number of healthcare workers that need to rely on the disposable respirators, which we are likely to run out of. So purchasing the reusable respirators ahead of time will save us money in the long run and could potentially help protect our healthcare workers. It is also important that we continue to stockpile N95s because right now most staff in a hospital or a healthcare facility are going to be wearing N95s. We're never going to have the entire staff wearing reusable respirators. You can't wear them in the ORs, and it's just too costly for everybody to have a reusable respirator. So you have to have access to some stockpiled N95s. And then we have to plan for long-term use because we know that many healthcare workers are going to have to wear the respiratory protection for, if not entire shifts, very long periods of time, probably multiple shifts in a row, and probably for weeks or potentially months at a time. And that does have impacts on the healthcare workers. So from a science standpoint, the healthcare workers are physiologically okay. They're fine from a medical standpoint in terms of wearing the N95 or the N95 and mask combination, but they perceive that they're very uncomfortable. They perceive that they can't breathe, that it's causing an issue with them. And that's going to affect how long they're willing to wear it and potentially how compliant they are while they're wearing it, because they might be readjusting it to try to make it more comfortable, even though physiologically they're doing just fine. So it's really important that we plan breaks in for healthcare workers so that they're not trying to wear the N95 respirator for their entire shift. And we need to be aware that obese staff are probably going to need more frequent respirator breaks because they did have more significant negative effects from wearing those N95s and mask combinations compared to our non-obese staff. Lastly, I wanted to let you know if you're interested, not just in, obviously you're interested in disaster preparedness or you wouldn't be a member of AHEP, but if you're interested particularly in infectious disease disasters, St. Louis University, the program where I work, we have a number of educational opportunities related to, specifically to infectious disease disasters. We have a graduate certificate in biosecurity and disaster preparedness. It's completely online. It consists of 15 credits, so it's 5 classes. You can complete that in 1 year, and all of the classes are specific to biosecurity and disaster preparedness. We also offer an MPH, a Master's of Public Health, where you can have a concentration in biosecurity and disaster preparedness. That is also available completely online. And you can also combine it, if you're willing to come to St. Louis, with a joint concentration with epidemiology or a joint concentration with global health. As you all probably know, this is a very emerging field in terms of having specific information related to biosecurity that's separate from just the regular emergency management, disaster preparedness, planning tools and knowledge that all of us have. We have seen excellent career growth opportunities in our graduates with outstanding salaries. So if you're interested, especially in preparing for things like Ebola, SARS, COVID-19, bioterrorism, pandemics, please reach out to me about the Biosecurity and Disaster Preparedness Program. I'd be happy to tell you more about those opportunities. So it is important that we prepare for these infectious disease disasters. There will be another one. It's not a matter of if, it's a matter of when. It's just as inevitable as death and taxes. So as disaster planners, we need to be building this into our plans because there are these very unique challenges. So what I hope you learned today is that it's very likely that we're going to run out of N95 respirators during a future infectious disease disaster. So as disaster planners, we really have to be planning to have access to respiratory protection to protect our healthcare workers. And this can consist of both reusable and or disposable respirators like N95s. And we, in addition, have to build in plans for the long-term use of respirators to make sure that our staff are protected and compliant and able to tolerate that so that they don't accidentally expose themselves. So I will now take questions, and my contact information is also on the slides. So feel free to email me or you can call me if you have any questions.
Thank you, Dr. Redman. Oh my gosh, so much information and so much timely and useful information. I can't begin to tell you how appreciative I am of you taking the time to share with us today. That being said, if anybody has questions, I know we're way over time, and if you're not worried about it, I'm not worried about it. Feel free to ask your questions in the chat box. You can unmute your microphone if you have a microphone and would rather ask a question that way. Either is fine. Go ahead and ask any questions that you have. I know there was one question about what university you are at. Just a reminder, so that was St. Louis University. And then here's the next question is, why has the U.S. not developed surgical capacity for production of N95 masks when needed, as well as increased production and distribution of reusable respiratory protection? We seem to be very behind the 8 ball on this. Any comments?
I agree completely that we are behind the 8 ball. And, you know, in general, you know, from working in disaster planning that most vendors have gone to just-in-time production for many types of medical supplies, including medical countermeasures, medical equipment, medical supplies. So it's not surprising that our PPE supplies fall under that same just-in-time production model, which means that we're not able to obtain it when we need it. And one of the factors that, in addition to not being able to sort of ramp up response and be able to obtain more in advance, we're not able to stockpile as many respirators as we need for lack of space and lack of money. So every year when now it's ASPR that runs the Strategic National Stockpile, there are decisions that are made by an expert panel that decide of the funding that we have available for our federal stockpile, what is going to be purchased, what has expired, what have we deployed and needs to be replaced, and how are those limited dollars going to be spent. And so respirators and masks are just 2 items out of many that are in our federal stockpile, and local and regional stockpiles as well. So we're constantly making decisions about what are the priorities and how are we going to spend those limited funds. So it's not surprising that we're not able to stockpile as many respirators as we need. The issue about why more places aren't using reusable respirators, that one's a little bit more unclear to me, because in the last couple of years, there was a lot of research dollars invested in studying reusable respirators and the use of PAPRs and the use of the elastomeric respirators to see what the benefits and barriers were. So there's a lot of great research, recent research that's available on that topic, but it just hasn't been embraced by healthcare facilities. And I don't know why that is. I don't know if disaster planners aren't aware. I don't know if there's a lack of funding to purchase that equipment. I don't know if maybe there's just a resistance because they think healthcare personnel won't want to use the reusable respirators. I'm not sure, but it is a very interesting question.
Any other questions for Dr. Redmond while we have her on the line? Again, this webinar has been recorded, and I will post that. Oh, let's see. You're just getting some thank yous. I thought maybe there were some more questions in the comment box. Oh, see, to ensure compliance. Let's see. During Ebola, mirrors and observers were used to ensure compliance. Is that being used now?
That is not currently, as of last night, that was not being recommended by the CDC. And my guess is that it probably relates a little bit to the feasibility. That with Ebola, at least in the United States, we had a limited number of infected individuals. And if we had had a massive patient surge, I don't know how feasible it would have been to sustain having an observer watch people put on and take off their PPE. And so I'm guessing, you'd really have to ask the CDC about this, but my guess is that when you look at pandemic planning and the number of patients and the very large patient surge, I just don't see how it would be feasible to have somebody dedicated to watching staff, so many staff, putting on and taking on their equipment. It's also a little bit different because the PPE for Ebola was much more extensive than the PPE that they were recommending for COVID-19. So there were more opportunities for accidental mistakes with the PPE for Ebola versus what we're using for COVID-19.
Looks like the comment back is that they did this in Sierra Leone with huge numbers. So Susan, you must have been a responder or a healthcare worker responding to Ebola. So, I mean, I'm sure we could take some lessons.
Yes.
Anyway, I just want to thank you again for sharing your time with us today, and appreciate your all of your information and all the research that you're doing. The contact information for Dr. Redmond is in front of you now. I will send the email, or I will email a link to the recording once I have that complete. And stay safe out there and wash your hands.
I will also send a PDF of my handouts to Christy, and she can distribute that so that you have a copy of the slides, which will also have my contact information.
Excellent. Thank you.
Sure.
Have
Thanks
a
for
great
having
day.
me. You too.
Thank you so much.